Hello, everybody. Hopefully you can see us okay. Let's see if our cameras are on. Okay. Hello, everybody. My name's Chris Hayes. I'm going to be presenting to you for the next hour or so. Hopefully you can see my video. So I'll just see if you can see the video or not. Bear with me. Okay, so you can hear, great, excellent, fantastic. And can you guys see me okay? I just want to double check, I'm not videotaping myself on my own. Let's just get this going. So,
Yeah, looks good.
colleague
Looks good.
who's here too. Rob, are you there?
Yeah, can you hear me now, Chris?
Yeah, I just can't see you, but maybe you're hidden here.
Yeah, I'm there. I'm there.
Okay, excellent. So I welcome everybody to our presentation today, focusing on building some confidence with we're working with trauma. My name is Chris Hayes. I'm a clinical psychologist based in Perth in Australia. And I'm with Rob here, Rob Brockman. Rob, do you want to say something? Do you want to introduce yourself too?
Yeah. Thanks, Chris, for coming along. And today we're going to hear about your working with trauma clients with a schema therapy perspective and, of course, imagery rescripting. So I'm going to be here to support Chris today as he goes through all the material. I'm sure people will have questions along the way. Please make use of the Q&A tab at the bottom if you're following us by Zoom. If you're following us via Facebook, I think you'll also have a capability to make a comment. And I can see that we've got someone there that's already made a comment. So make a comment via the comment section on Facebook in terms of questions, or the Q&A tab at the bottom if you're following us by Zoom. All right, Chris, so over to you.
Yeah, look, yeah, so I can see some of you guys have put up questions in as well. So we're going to stop for some questions sort of midpoint. This should go for about an hour, but there's quite a bit of material to go through. So but just to give you a bit of background about me, I'm a clinical psychologist in Perth. My background in terms of trauma, I've been working for the last 7 years, working at a specialist treatment service, focusing on sexual sort of trauma. So it's usually sexual abuse or sexual assaults. And this is part of the WA, Western Australian Health Department, the government service here. So I've been a part of the imagery rescripting and EMDR research trial that's been happening in the last couple of years as a quasi minion providing the therapy. But also, as you know, we do lots of training, and this is a part of our free training that we're providing to you guys as a part of our schema therapy training online. If you're interested in this sort of stuff, you might want to look at the imagery scripting training that we're going to be, it's going to be coming up in the next couple of weeks as a next course. But we're also looking at developing a course looking at schema therapy and working with trauma, because there's a lot of people that seemingly are very interested in this. And even from a personal perspective, it was something that was quite challenging, and is you want to get confident working with these sorts of populations. So I guess what the reason really I wanted to kind of talk a bit about trauma and getting more confident is I supervise a lot of people working with traumatic presentations, and even for my own self, when I remember starting my job working with sexual abuse and sexual trauma, it was a little daunting, and I was at the time I was sort of my vulnerable side was freaking out a little bit, but it's something that, we can kind of learn some skills about conceptualizing a lot of, we have a lot of fears working with trauma often, and some of that can be triggering for the therapist. And hopefully by the end of this, we might have some ideas about how we can, sort of manage those fears and have a bit of a structure to be able to move things forward and to work with clients with a traumatic background. So, why think about trauma? Well, if we're just thinking about the research background of schema therapy, obviously we're working with a lot of personality disorders, and there's a big focus working with borderline personality disorder. And there's lots of research that suggests that, there's clients that have borderline personality disorder. They also have traumatic events happening to them. If we're looking at BPD, it doesn't require a big T trauma. And what I mean by a big T trauma, we're talking about, events that might be, threatening to the life of someone. It might be serious, where there's seriously high levels of anxiety and shame. There's high levels of, very threatening abuse. Clients don't necessarily need that to meet the criteria for borderline personality disorder, but they might have a lot of little T traumas, and these might be more sort of general kind of events that are unfavorable, that are painful, that aren't in the same boat as what a traumatic PTSD kind of experience would be. But there's, obviously a bit of debate and a bit of conversation about what we would call complex PTSD and PTSD. And complex PTSD is often mixed, and there's a fair bit of debate looking at whether clients are complex PTSD or are they got a borderline presentation. So, as we can already see, there's, if you've got a client with a borderline presentation, there's a possible, issue there with these clients having experienced, sexual abuse and these sorts of things, and maybe events in their adulthood. But also, if we've got clients that have had repeated events happen to them where it's very high levels of distress, high levels of shame and anxiety, these might be set in more of a complex PTSD. So some of you guys might know this already, but when we're looking at someone who is presenting with PTSD, when I'm talking with my clients and my supervisees, we tend to think about three main symptoms. People feel raw, okay, R-A-W. They're having re-experiencing symptoms, they're having flashbacks, they might have body memory, strong emotional reactions, nightmares, these sorts of things. So the re-experiencing R. A is a sense of agitation or anxiety. So we're talking this sense of threat here. And the third thing is W, which would be sort of withdrawal and avoidance. So if you've got a classic kind of, Axis 1 presentation, PTSD, you're getting these sorts of three different clusters of symptoms. But then if we're looking at kind of more complex PTSD, we're getting, symptoms that might sound a little bit more personality disorders, based. So interpersonal disturbances, having difficulty maintaining relationships with others, either that there's strong emotions that get in the way, or they're avoiding the emotions altogether, avoiding getting close to people altogether. There's often negative self-concept, which again is sort of often, viewed as a part of a BPD diagnosis. These clients hate themselves, they feel useless and horrible. And the third thing is emotional dysregulation, so clients having difficulty managing emotions and so forth. So, when you kind of think about complex PTSD, we're kind of thinking, well, is it maybe some of our clients that we're working with are coming from that trauma kind of place. So I want you to kind of stop for a tick and just maybe, it'd be good if you kind of whacked it up in the Q&A as well, just to validate as well for others, because others can possibly see it as well. I'm not sure how it works, but it'd be good to have a think about what are your fears about doing work with clients that have been traumatized in their childhood or possibly in their adulthood. It's very normal for therapists to feel like they might make it worse, or that they're encroaching on the client and pushing something, or that they're going to re-traumatize the client. These are very, very common sort of things that the average therapist might have. It might be like it's kind of awkward and I don't really know how to address it. How much do I address? Do I need to go through the whole thing? Do I need to just talk a bit about this, or what's going to be useful for the client? So these are all things that therapists like us, we struggle with. And, getting confident with this is going to be really helpful for you and ultimately for your clients. And it's not nice stuff sometimes, particularly the childhood stuff and, obviously adult stuff. And often this is interpersonal as well. A lot of abuse and childhood neglect and experiences like this, it's different from, something like a bushfire or a plane crash or a car accident where it's not interpersonal. These things often can really, really deeply affect people's attachments to caregivers and family life and these sorts of things. And it can be kind of complicated. So what I want you to consider is this idea of, if you were sitting in the webinar with me right now and you actually had a screaming toothache, like your tooth was just really, really, you were struggling and you really, really were feeling it. There might be some issues with that, maybe, you might not really be that interested in hearing this. You might be angry because you're having to put up with the pain and listen to me. If someone walked in and bugged you, you might be short at them. You might be, revved up and worried that you can, you get to, cope well with the presentation, this sort of thing. And what I often, encourage people to think about is, whether trauma work should be more of the focus, for a lot of our clients. If you've got a toothache and the tooth is, a big problem, we can look at strategies, we can look at, ways to manage feelings and this sort of thing. But at one point, it's going to be useful for you to maybe do some work with the tooth, be the dentist. So there's a bit of a conversation that you might, have with yourself, whether do I need to do some work where if I do some trauma-focused work, whether the tooth is helped, or do I focus on ways to manage the feelings and distress and, all the things that go with that. And for some clients, I think it is around focusing on the trauma is the key thing. And if we do that and we're able to reduce the distress around this, then we can, a lot of these other problems that might be apparent might just be solved solved on their own. So, this idea of the toothache, there's a psychological toothache, and maybe we need to focus on that. Now, when we're assessing clients, another issue that we tend to kind of find with therapists is, we've all been there, I've certainly been there, is a client presents, they might not be presenting necessarily for stuff to do with traumatic events in their childhood, but they may be dysregulated, they've got problems, things are going on for them. And, sometimes it's about asking the right questions. Excuse me. Just to go back to the basics of schemas and modes, we've got this idea of temperament meets, maybe a caregiving mismatch. If clients aren't getting their needs met and, they're kind of not getting what they need. But we're also kind of having traumatic events. Now, these traumatic events might be big T traumas. So if it is, events of being, sort of abused or hurt, or there might be deaths or illnesses or attachment things that are happening. These things are interacting with those other two factors. Okay, so often it's useful to ask about traumatic experiences. I know for myself, when I started to do this sort of more trauma-focused kind of work, I didn't necessarily ask. And it goes back to this idea, if you don't ask, people aren't necessarily going to tell you. And then you're going to be 3 years into therapy and they will say something like, did I tell you about what happened to my uncle with my, yeah. And then that will be the missing piece for the client. So there's something that I often will use with a lot of my clients, and I encourage people to use, is the Life Events Checklist 5. It's a really easy thing that you could kind of incorporate into your work. And here's an example of some of these sort of things here where we can kind of look at particular events and, sort of screen for things. I personally like the exposure to toxic substances, for example, radiation. I mean, it's quite specific. But, we can ask about that. Like, tell me about that time in Chernobyl when you're on holiday there and you got caught up with Chernobyl. Ordinarily, clients wouldn't necessarily tell you about this. You don't have to go in deep and talk about it a lot. You can make that a point, that we don't necessarily need to go into detail about things until you feel comfortable or okay about that. But it might be useful for me to know. It's a very easy thing that you can start to sort of put into place. Now, processing trauma and doing preparation they're two different things. And there's quite a bit of debate at the moment in terms of some of the previous kind of focused work on everybody should be doing more of a phase-based approach to trauma. So the phase-based approach to trauma usually is around the idea that client needs to have resources and there's a stabilization phase. Client needs to clearly have this stabilization phase before you can do trauma-focused work. And there is quite a bit of debate at the moment looking at whether that is necessarily true. So for example, Rob, put out this study a couple of years ago looking at preparation in terms of affect regulation and skills training with imagery didn't enhance the process, didn't enhance the imagery rescripting process for clients. De Jong, who's EMDR treatment academic in the Netherlands, is looking at using EMDR, using it to get in and process traumas and really focusing on doing like a boot camp focused on EMDR. So if you're interested in that, it's called PsyTrek program. And the problem is that sometimes when clients are presenting, and they've gone from 4 or 5 different clinicians and they've never really done any sort of trauma work, they're never getting a chance to have the corrective emotional experiences that you could be getting from imagery. They're not able to kind of work through this because therapist is stabilizing to some extent, and then the therapy's ending or they're dropping out and these sorts of things. One thing that really got me a couple of years ago is one of my colleagues at my health department job said that she read some story about this little girl who experienced sexual abuse as a child, and she went to major teaching hospital and was getting looked after by one of the therapists there and treating team. And she was there for 2-3 years, regularly seeing this psychologist. And then she, got older. She was sort of 13, 14, and didn't meet the criteria for that service. So she went to another service where they were working with more teenagers. And the new therapist came and said, "Listen, so what have you talked to anyone about what actually happened with your dad?" And the girl that was there, and she wasn't trying to be facetious or anything, she said, "No, I don't think my therapist was ready." And that really struck me, and it's a take-home point that sometimes you have to think and consider: is the avoidance, or is this about a healthy adult therapist avoidance, or is it that we are feeling awkward about dealing with a traumatic event, or not skilled enough, and these sorts of things, and then that's a missed opportunity for the client. Also, just to further, the idea around phase-based approaches, this is a brand new study. This is the study that I was involved in as a clinician. It was released last week. I think I emailed people as a part of the Schema Therapy Online, just noting this. This is a big study. This is a really big study looking at imagery scripting or EMDR, standalone treatment. There's no schema talk in it. You're going straight in, doing the work, 12 sessions. Every session you're doing either imagery or EMDR. These clients are complicated. These clients are mainstream mental health, government mental health type clients. They're not, but they were willing and they were seeking treatment for childhood trauma. And massive effect sizes. Clients that, you didn't need the stabilization. The clients went in, did the imagery or did the EMDR. No difference really between the two. EMDR reduced quicker, but over time, after a 6-month follow-up, to both of the interventions are the same. So, you know, there's something about doing some trauma-focused work that can really help with avoidance. And avoidance is the thing that's going to be shutting down any prospect of change in terms of the trauma side of things. And that's going to be your detached protector or your avoidant protector or other coping modes that are getting in the way. If a client wants to do some trauma work, I would proceed and talk with them about that and work with them. They might not be wanting to jump in straight away, and we'll talk about ways that we can kind of work with that. But, you know, there's ways that we can kind of approach things. So, Rob, we might stop for a tick there. Any questions? There's a couple of questions up here, but yeah, do you want to, I don't know whether people can see them or not.
Sure. I mean, I've collecting them a little bit. So I think there's one here from Gillian, and she talks about the issue of stabilization, which you brought up, Chris.
Yep.
And she asked the question, do we stabilize and resource first or jump in? Okay. Now, I know you talked about that a little bit, but I guess it speaks to, you know, you presented some of the evidence for why we really need to jump in. I guess the question for you would be, in your work in schema therapy, do you ever spend any time on stabilization for different clients, and when and how would you make that decision?
Well, if a client is willing to do some trauma-focused work, that's a good sign. Often clients will be like, oh, I don't want to talk about it. And then you could be stuck working with coping modes until that time comes. If clients are wanting that, that's a different thing. Now, whether we jump in, this is about sort of working out where the client's at and you assessing that. I wouldn't necessarily say we have to go through this whole, you know, stabilization thing for everyone, but it might be that you start to do experiential stuff like imagery scripting and you're using that as a resource. So it's not an and or thing. You could be doing things. Now, easy thing you could be doing is doing imagery scripting, maybe taking out all the antagonists. So, you know, it's just like get an image of you feeling scared, alone as a child. And I want you to get a sense of that. Can you see that? Great. Okay, where are you? Da, 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 da. Okay, and bringing me into the image. And then you would just be focusing on providing safety or care or whatever. So that could be a good sort of entry point to these sorts of things where it's not, you know, and or. We're going to talk a little bit about some guidelines as well about that in a moment. But yeah, I think, you know your client. I definitely think sometimes you have to consider is my avoidance based on me or the client, and sort of thing.
What I'm hearing from you is you don't necessarily see it as like a phase-based thing, but you'd like to try to bring some focus on the feelings and on the trauma as soon as the client can. And if you do some stabilization-based things, you would mix that in with a little bit of experiential stuff to get the process going.
Yeah,
using principles of sort of you know, hierarchies and slicing it thin and seeing what it is they can tolerate.
Yep, and working within that window of tolerance. So it's not like no, we got to be resourced to do any trauma work. You might want to start to get the client into that window of tolerance. It's a big trauma concept where you're trying to have that kind of sweet spot where the client's feeling something, or they're not feeling flooded and they're not feeling detached and dissociated and cut off. So you want them to feel, get better at feeling things. And that's a part of the resourcing, really. So, yeah.
Yep. A couple more questions here. How stable does a client need to be, you know, to engage in imagery scripting if they have PTSD? You know, and for example, this is from Natalie, you know, what if they're homeless or they're very irregular in their attendance or for whatever reason? And how stable do they need to be in their life to benefit from this kind of imagery work?
Yeah, that's a good question. I think you'd need to have some sense of safety. It would be difficult to do it. Look, one imagery isn't going to do it. It's going to be a certain sequence of work. So if someone, for example, was homeless, I would be wanting them to at least have some stability in that sense, in terms of having some safety where they can kind of do some work over 2 months or 6 weeks, and then sort of have some benefits from that, rather than having to deal with the crises that go with that sort of thing. So I think, that's not a bad way to be, but it's different from, sort of the stabilization and all cost side of things too. Yeah.
Another one from Sean, Chris. Can complex PTSD clients be more over-regulated emotionally rather than dysregulated?
Yeah, so if you've got clients that have got really strong overcompensation modes, they might be over regulated. So I think that's what you mean. So you might find that clients, they've developed very strong ways of coping. So it might be, we're going to mention this a bit later, but often self-criticism might look like an interject, like a parent mode, but it also can be an example of a kind of a coping mode.
And the over-regulation, I guess, I would think the schema model does pretty well because we have a whole range of coping modes like detach protector or, all these different forms of over-regulation, which we can work within the schema model. Like we're not just going in blind and sort of, we have some ways of working with that sort of over-regulation.
Yeah, absolutely.
Yeah.
So we might kick on for a bit and we can answer a couple more questions. Keep whacking them up there. Thanks, Rob.
Nice questions, people. Let's keep them coming.
It's some of the stuff we've just referred to a little bit here as well, but you do need to consider your time and scope of the client. If the client's homeless or you've got to see them for 5 sessions, then you're not going to be doing necessarily, trauma work. If you're finding yourself really anxious and not confident about things, you're going to need some ways to feel more confident about that. So it might be come from supervision or doing some training, this sort of thing. But is the inaction, is it ultimately for the client? And I'm not saying it's inaction. Sometimes we're just focusing on, in other approaches, it might be just resourcing, but, we need to get that balance right between over-resourcing and not actually talking about, the difficulties and this sort of thing. So I'm going to sort of move into a couple of, this is about building up confidence. So, one, way to build up confidence is to try and help with conceptualization. I remember when I started doing more sexual abuse type work, I was kind of like a bit, what do I do? What do I talk about? What's taboo? What's not taboo? And these sorts of things. And ultimately, it's really about the legacy. It's not necessarily about what happened or what was done to whom. It's the legacy, the emotional legacy, the re-experiencing legacy, and the cognitions and the meaning and the schemas that that result for this, present for this client. So, this is a sort of a part of what we have put together for, in the research trial. If you're interested, great book, really fantastic article with Katrina Bodehoven-Dahan and Chris Lee. They do a great little, chapter, not little chapter, but great chapter looking at imagery scripting for PTSD based on the research trial. And, we talk a bit about this idea. This is something that we would talk about with clients, that, if there's a particular memory that is a bit of a difficult memory, and then we would want to look at processing, you kind of want to split it up into 3 bits. You want to look at the emotional element of the memory. So, when you get that image, for example, of, dad comes into the, coming into the room. Okay, what's the feeling? So in this case, it might be fear. There's a physical reaction to that. Sensory element might be, I can hear him walking down this, the stairs, or I can see the light and him coming into my room. That's the obviously, often trauma memories are visually encoded. So, that's a very common thing. So often we get a visual element to the memory and the trauma. And then there's the meaning. Okay, so the meaning, we want to see what's the bottom line, what's the cognition, and why is this schema? Okay, so there's going to be probably a particular schema or a meaning, core belief element to this, and it's worth exploring that and getting that assessed with the client. And we would move this into possibly doing more maps where you would sort of look at a theme And it might be the particular most difficult memory that the client, feels like that's a big part of the toothache. And you could be looking at, okay, what's other memories that are linked to that theme, that idea, that schema. Now, in more sexual trauma, given this is a bit of an area that I've been working within, there's a couple of key schemas that you're going to be seeing come up for clients. So, classic one would be, the image of dad coming into my room, feeling of shame, believe I'm to blame, I should have stopped it, what's wrong with me, this sort of thing. So it's going to be more about a defectiveness schema. Another very common one would be more about subjugation. So a sense of power, control, coercion to doing things, feeling powerless. So, this belief I'm powerless, I can't stop this, I can't make it better, this sort of thing. This could be really related to more of a subjugation kind of profile. Again, a different kind of element might be more about mistrust and abuse. I'm not safe, others aren't there, they're going to let me down, they're not going to make it okay. I can't trust others to make it okay for me. And the fourth thing that you often might see is it might relate to perpetrators, not so much the perpetrator sometimes, it might be sort of extraneous kind of family and this sort of stuff where it's more about emotional deprivation. It's like no one was there for me, no one helped me, no one protected me. And that might be more related to a sense of loss or sadness or these sorts of things. So again, these are just sort of things that you want to kind of conceptualize and to sort of spot and be able to kind of see coming up for clients that are really attuned to their experience. Again, it's about confidence again. Like, some of these, you have some complexities working with kind of sexual trauma. So one thing, that you want to keep in back of your mind is this idea of things like grooming. Grooming can be very confusing for someone. Okay, so if someone's been, abused and there's a grooming process, you might have different. It sits really well with our schema model because it might be the vulnerable part of the client feels like he or she, tends to me, cares about me, is doing these nice things to me, but then there's another side where they're not doing that. So clients can have very mixed feelings about perpetrators where there's really high levels of grooming because often it meets a need. If they've been ignored and they're vulnerable and they're exposed, then, perpetrators often will exploit that need. And also it can be very glacial. One of my clients referred it to that way, that the abuse was, it just felt like it, it didn't start and stop. It just slowly happened over time. And then suddenly I was here and I didn't realize and I didn't, it'd been normalized. So it can, again, be very, very complicated for clients, and it's helpful for them to get a bit of education around that. Same thing goes with caregivers' responses. Often, if you've had some experience working with clients with this sort of thing, is that caregivers' responses are very, very impacting. So clients that, aren't believed, or, maybe there's the mother that isn't, a supporter or is angry because, they've disrupted the family system and this sort of stuff. Another thing, it's probably the biggest taboo working with clients is it goes to, some extent grooming, but, it's this idea that, some clients might have positive arousal to, experiences. And that's extremely shaming, extremely uncomfortable. So it's really important for the therapist to have that normalizing experience and talking about your body just takes over. It's not about you, it's your body. I used to say to people, like if I went like that to you, what happened with your eyes? They blinked. Did you choose to blink? No. So what's that about? So sometimes your body does things based on stimuli that's nothing to do with you. But in this situation, the clients were blaming themselves, giving themselves, horrible, the punitive side might be really kicking in. Also, in regards to self-blame about getting away or not protecting themselves, talking to clients, using polyvagal theory by Stephen Porges, looking at this, educating the client that this is your body just shutting down. If you don't, you flop, what is it? You fight, flight, freeze, or flop. And sometimes you just shut down. It's a feigned death response. You're just trying to manage and survive. Often working with detached protective, you have had lots of secrecy. You've been told to keep things secret. You've been told to deny, accommodate, this sort of stuff. Again, that can be really helpful for you to educate the client around that. How does that, affect the development of a detached protector mode? Also things like grief. When you've got clients that have realized that their childhood has been not ideal, that can be a very normalizing experience, and helping the client to kind of work with that and process that, and providing limited parenting around that, rather than shutting down or blaming themselves, having these feelings. And again, like I said before, different modes might have different loyalties. So you might have a child part of the client that has more loyalties or positive experiences to particular people, perpetrators, but then the healthy side has a completely different loyalty. So these are important things to mode out with your clients and these sorts of things. Now, another thing I wanted to bring up was this idea around self-criticism. If we've worked with schema model, a classic thing would be, someone's self-blaming, we automatically go punitive parent. That's punitive critic, parent, and there's that side of you that's abusing yourself. That's an introject that you've learned to be mean to yourself. But particularly in childhood abuse, where there's a lot of powerlessness and there is no way to run away or just give in and be good, sometimes you are gonna develop a side to over-regulate, as we mentioned before. So you're going to be overcompensating. You can be really horrible to yourself as a way to keep it together, so you don't be vulnerable, so you don't show emotion, so you're not punished and things are made worse. Now, there's a EMDR therapist, and I really like this sort of concept, where he would talk about the idea of coping as a kid. This idea of self-blame. It can be, it's better to be a bad kid in a good family than a good kid in a bad family, because the horror and it's mind-blowing to think that. It's much more, easier to accommodate that, to minimize that, or, sort of change that around. So when we're looking at these sorts of clients, don't automatically think that there's, some sort of critic is a problem mode. It's about parent mode, critic mode. We're trying to get rid of that. Often you will want to kind of look at what's the function of that mode. If the function is to get back on top of it, shut feelings down, then this is something that's more about coping. And this is one of the benefits of the schema model, is that, we might have a critic, but we can have different functions of that. And it's quite useful in terms of formulation. So again, an EMDR practitioner, I went to a workshop a couple of years back, and I took a lot from this particular workshop. This lady, Joni Spearings, and people are always asking me, when do we process clients? When do we process trauma for clients? And look, there's a couple of things that we want to keep in mind. First thing is, does the client have any capacity to be compassionate to themselves? If they don't, that's a problem. I can't see, a client moving forward if they hate themselves, if they blame themselves, this sort of thing. So if a client, has capacity to be compassionate, check. Next one is, are they able to have some attachment to another person, either to you or to someone else? Do they have any healthy relationships at all? Are they able to kind of open up to you to some extent? So to some extent, if you're going to be talking about painful, traumatic memories, they're going to have to get rid of a coping mode or bypass a coping mode. And the third thing is, if the client is completely unable to regulate their emotions. Okay, so there's difference between, a client that is totally overwhelmed, can't regulate their emotions, between someone that you're learning or you're kind of gravitating and helping them to get to this piece. So you want to, maybe you have these in the back of your mind. If a client can do these three things, then, maybe that's time to focus on the more of the trauma material. So in terms of the attachment side of things, you know, you might want to do some preparatory stuff around, okay, if we were going to do some work on your trauma, let's help you get closer to other people. You know, maybe there's some ways of opening up to me or others in your life and improving relational stuff. So that could be kind of a helpful way, help to have some healthy attachments to other people. Second thing, compassion. Now, you know, Joan Farrell and Ida Shaw, they do a great imagery exercise of the girl on the street. You know, it's a great, you know, if you haven't heard of it, you know, check it out. It's, you know, you're leaving the session, you're walking back to your car, you hear a little girl crying. She's the same gender as you. You can't see her face, but just notice what feelings you got. How are you feeling? What's running through your mind? You're going a little closer, still can't see her face. How do you feel? Feeling really, you know, preoccupied about her, worried about her, wanting to make it better. And you're going through this process, and then all of a sudden this little child turns around and you realize it's you as a child. Okay, so from that point, it's an assessment. You're assessing where the person's at. If the person has compassion, then happy days. If the person flips, which often they might flip into some sort of punitive critic or something like this, then, you know, that's something to talk about. That's data. That's something to discuss. So, you know, compassion is really the view of the self from the healthy adult. You know, I like the idea that, you know, what is it? You know, it's not what you see, it's how you look. This idea. So, you know, you might want to look at other things that are blocking compassion. So maybe clients have had difficulties in the past relationships to tolerate positive effects. You know, so you being kind to them might be feeling really uncomfortable because it reminds them of how perpetrators treated them. Might be just tolerating positive emotions. The detachment, if you've got a strong detached protector, or my client calls, you know, she's got the nope mode. Nope. You know, nope mode doesn't let good emotions in and bad emotions in. So it just keeps it shut out. So, you know, doing mode work around this, understanding what the block is in terms of being kinder and more compassionate to the self would be really useful. You know, using childhood photographs. You know, that could be a really profound thing that isn't full trauma processing, but it's preparatory and helpful to help the client, you know. But we could also, you know, be getting the photographs. What do you make of this little kid? Does a part of you feel sad for this child and what he's been going through? You know, you look at that photo. Wow, you know, it makes me feel sad to know that that's what she went through. This sort of stuff. So you could be doing lots of liminary parenting, and you're modeling what the healthy adult is for the client. And that's one of the benefits in the schema model is the liminary parenting is a part of the architecture, and it's helping to meet the client's need of safety and care, which might not be as prescribed and as specific in, say, other approaches, say, for example, EMDR. Another thing, you know, you might want to consider is to do imagery scripting, like I mentioned before, where you take out the antagonists and you're just focusing on being, you know, kind, nurturing, and doing work like that. It could be that you're doing some, you know, working the client up to doing work with more difficult, you know, clients, different difficult antagonists, but it doesn't have to be big T trauma stuff. And it can be also really reassuring to the client that you don't have to go and relive some of this stuff necessarily. You know, like, so if we're doing imagery scripting and we're using that as the primary thing as a part of the trauma processing, just the imagery scripting, it can be, you're always going up to the point, you know, you're not going through that, you know, trauma, you know, sort of checkpoint where you're going into what happened. There's been plenty of events where I've gone where we go up to the point and we know that something's about to happen, but then I come in and provide safety and care and respond to the antagonist and win the exchange. So, you know, a lot of this sort of stuff is included in our, you know, imagery scripting for childhood trauma and schema therapy training that we've got. And the idea around winning the exchange and dealing with different types of antagonists, if it's, based on trauma or more on a schema level. So these things could be, really helpful to sort of try and build up some sense of compassion and this sort of stuff. And also, just in terms of managing big feelings, we're talking the third thing about sort of being able to help clients become better at managing feelings. Like I mentioned, limited repairing is a big part of the treatment. We're trying to get the client to feel something, but we're trying to provide the corrective emotional experience to help soothe, help down-regulate, help them get their needs met. So it's really important we use those ideas around limited repairing. Other things we could be doing is in terms of grounding techniques, up into, it's lots of sensory type stuff. I've got this ball thing that's on the picture here that we go into Kmart and buy a couple of these balls, and we'd be throwing the ball together at each other, catching the ball, and watching the ball. This one pulsates. It's got like a little LED light in it to get the client out of their head and into the room. You also might be just throwing a pillow at each other in a kind way, but like, just where are you right now? What day is it? And this, sort of mild stimulating kind of in the room, here and now stuff will often help clients come back into the room when they've got high dissociation, overwhelmed. Different therapists call things different things. Some people, use a shawl or I kind of talk about the hug rug for me. So I kind of might throw the client a rug, hold it at the end. Hey, I care about you. It could be a way to down regulate the client, get back into that window of tolerance where they're not totally overwhelmed, and they're just, feeling their needs are getting met. Transitional objects. So you might be doing imagery or just outside a session. You could be giving the client, a transitional object, for example, this rock. I want you to think, someone cares about you. Someone's got your back. Someone that, is helping you move forward, and someone has you in mind. When you look at that rock, think that someone has you in mind. That's me. So when you're away from the session, there's something a little more emotionally connecting. DBT, it's fantastic. Some of the what they call tip skills, it's worth having a look at. So the intense temperature, you might be, when the client's really overwhelmed, jumping in the shower, cold shower. So it's temperature, intense exercise, going for a run, getting really emotionally or physically charged, sort of physical activity. Progressive muscle relaxation, so TIP. Some of those things can be useful to be integrated into the schema model to help clients, manage these sorts of experiences. And if you're interested, I won't spend too much time now, but there's a concept called the back of the head scale. Again, it's an EMDR technique, but you might be interested in typing that into the net, looking at that. But this is kind of a way that we can sort of get a subjective, element of dissociation. So we might be saying to clients, okay, there's a ruler that goes from the back of your head out to here, so 30 centimeters out here, 30 centimeters, you're in the room with me, not distracted by thoughts and feelings and memories. And then as we're going down, that's 15 centimeters, and then we're down to 10 centimeters. And then when we're less than say 10 to 15 centimeters, then we're starting to really go into our experience and become very absorbed by traumatic memories and experiences. And then we can kind of help do things like grounding or distraction, or do present orientating things like throwing balls and rugs and hug rugs to help the client come back into the room. So if you're interested in that, check that out. So just in summary, we're going to go to some questions, but one thing that's helpful is being confident when you work with clients with trauma is kind of handy. You got to fake it till you make it. Clients are very perceptive sometimes. They might be feeling very ashamed, very preoccupied, and very perceptive of your reactions to things. I always say to my supervisees, if you went to you had something wrong with your knee and you went to a surgeon, and the surgeon had a look at your knee and went, yeah, I guess I could give it a go. I did a workshop on the weekend. Yeah, why not? Why don't we give it a go? I guess we could try. It might not really help you feel confident with the process. So really keep that in mind, like this idea of for showing the client that you're confident with the experience and what's happening. Second thing is that is the client, are they ready to do this stuff? Go with those 3 ideas of compassion, emotional regulation, the ability to kind of, have relationships with other people. And maybe you look at some smaller goals that are going to lead to those things. So if you want a good one would be working on self-compassion and then, focusing on that. And you could still be using some experiential stuff like imagery and this sort of stuff without going for the big T stuff. And you bring that online. And look, the other thing I was going to suggest is, if you're going to do some trauma stuff, use it as a plug-in. Suggest to the client, why don't we do, say, 6 sessions where we're doing imagery in every session and use that, because that can be really helpful as well for the client, to avoid, avoidance effectively. So we're right on 60 minutes. That's insane. That's amazing. I didn't expect it to be that chop. But Rob, have you got any questions we could maybe have a quick look at?
Yeah, no, absolutely. We've been getting lots of questions coming through, lots of cool questions, actually. The first one, if I could hit you with, is from Rachel. Is there a typical trauma/PTSD mode map? How would you conceptualize the PTSD with, say, schema modes in a map?
Okay. Can people see me?
I'm sure they can see you.
There you go. Look, I don't think it is that easy, because sometimes their coping is different. But the classic kind of thing would be a vulnerable child, traumatized mode.
So I think about that, Chris, as the sort of often it's the PTSD memory is sort of within the vulnerable child, and it's like the vulnerable child is like a traumatized child. And
traumatized.
It's kind of stuck there.
Traumatized. Yeah, and you have to think, how does a little kid manage to deal with that stuff? So, it might be there's 1 or 2 ways of coping with that, and moving from that, then building up. Also there might be you might need to incorporate an angry child mode, because, effectively clients that have been subjugated and dominated, it's good to them to incorporate that, because that's about autonomy. You're angry as a kid to get a sense of say, and that's good for you to kind of maybe help build on that. And then sometimes they've got a strong, punitive critic. But yeah, I think it's case by case. Building that up.
And I've also, I guess, related to that about anger, and often trauma clients can have a lot of anger sort of connected to their PTSD memory. This is from Jackson. What techniques would you use to work more on the anger issues and aggressive outbursts in folks with a PTSD problem?
I would try and work out what mode is displaying anger. So it might be angry child, like I don't want to have to do this crappy freaking therapy and I'm over it and this sort of stuff. And it might be angry child stuff. Healthy anger might be, here's dad, he's the one that did this stuff to you. Okay, let's do an exercise. What do you want to say to dad? What do you want to say to him about how he treated you? Okay, focus on the healthy side. Are you sick and tired of having that in your head? Are you sick and tired of having those experiences? What do you want to say? So that could be more of a healthy anger, isn't it? So, one thing, is the anger empowering the client? Does the client feel more empowered from being that way? Because if often it's angry child, it's kind of like, it's not fair, this is horrible and this sort of stuff, and it's not necessarily kind of
in your cases, I guess, in the trial, and did you ever see cases where you do trauma processing of the past, and rather than it being more of a vulnerable affect coming up or even shame, it was a sort of outburst of anger, that in other words, the angry child kicking off along with the trauma?
Yeah, sometimes, but I wasn't. I'm trying to think of my experience. I wouldn't say that's very the norm. So
it tends to be, once you connect to the past and the child self, it tends to go more vulnerable.
Yeah, or to keep in mind, this angry, you might have like an overcompensation. So there could be sort of angry protector type thing that kind of kicks off with more complex trauma clients. They could kind of angry protector or sort of overcompensation that's sort of shutting it down too. But I wouldn't say it's the norm. But
So
you get the client to feel there's a sense of righteous indignation that's healthy. It's like I'm angry that this stuff happened to me, and I'm gonna. So when we're doing the imagery scripting, the first phase is when the therapist is going in and re-scripting. This is part of the research trial that we're part of. The second phase is when the client is going into the image and they are re-scripting and they are standing up for the child and standing up for themselves. They're looking after themselves, you know.
I guess in those ways they might even ventilate some healthy anger in looking after the child and learn to set boundaries in a healthy way.
Yep. Perfect. Yep.
Yeah.
You're validating the
Thanks, mate.
Yeah.
What about online space? Quite a few people interested in that. What do you? I don't want to go into generic schema therapy online because that's covered. We have a course on that with Z. Liu and Hagara Feldman. But can you say something about trauma processing in an online space, contraindications, and maybe is there any grounding techniques that you can use online?
Look, I think that you can do imagery easily online. You need to know your client. You probably need to have some sort of, if you're really worried about them, you know, I mean, I would have clients that, you know, I wouldn't necessarily feel like there's a phone, you know, dropped out, you know, I would be like, oh my God, like, you know, what's this person going to do? So you might want to have some backup in terms of contacting them and things like that. But, you know, I think things like imagery can be really helpful. I had one client, you know, she had some, you know, issue around when COVID kicked in. She preferred to do the imagery online, and, you know, we saw each other as well in person, and, you know, it made no difference at all. So sometimes you know, it's about, you know, kind of, I think it's more generic sort of stuff, setting up a safe space to do the imagery where you haven't got distractions and a bar fridge next to you and your family walking in on you when you're doing it, this sort of stuff. So
yeah, which is covered in the online course. Yep. And about the anger too, I thought I just mentioned, you and I actually covered this in a 1 hour What's the Schemata about a lot of the issues to do with anger and schema therapy. That might be worth looking at for those interested in the anger element.
First, we did. So if you're interested, we've got a podcast we put out once a month almost called What's the Schemata, that's available on iTunes and Apple Podcasts and Spotify. I think it's the first episode we did was working on anger and how to formulate that.
Now, another one here from someone anonymous, in conceptualizing childhood PTSD, right? What about those clients have supposedly privileged childhoods where there was more of an emotional neglect, you know, no sort of overt abuse necessarily, you know, can that feed in or be the cause of some PTSD, you know, and how might that change your approach?
I'm not too sure if it would cause PTSD per se, but it's definitely going to cause a lot of schema activation and probably going to be more around emotional deprivation. So, you know, clients that have had neglect, you know, or, you know, they've been privileged in terms of they've got all the, you know, the
So it tends not to sort of trigger off the whole range of PTSD symptoms, hypervigilance, all that kind of stuff.
No, but because you have to have something that's pervasively painful and distressing to kind of flash back to. You know, flashbacks about dad reading the paper on a Saturday morning when you really wanted him to talk to you, but you might have flashbacks of, you know, someone, you know, sort of harming you and then going back to that family and just not sort of, you know, kind of not being able to talk about it or feeling safe to share that knowledge of that. So
those more neglectful type memories might feed more into schema-based issues, and possibly in severe cases, even personality disorders, BPD.
Yeah, or that it might be just a don't ask, don't tell stuff. It's kind of like the client, you know, no one's asked them if has anything ever happened, you know, giving them a leg 5 and then suddenly, okay, some stuff happened here, but giving the client, you know, the right to not tell you about it, but just knowing that in the background will help you because there might be events.
Nice. Now I've got 3 more questions, quite good ones to get through. All right, we'll sort of limit setting. A question here from Jackson talking about, I'm curious on your opinion about whether it is best to work on one trauma at a time for a PTSD patient or dealing with multiple traumas at once.
I would map it out. So I would look at the most difficult one. If you're working in a really tight way, look at the most difficult traumatic experience that they think is really loaded up to the toothache, and then ask them to think of other memories that might be related to that theme. So mapping it out by kind of, so you might be like, maybe it's a subjugation theme.
So you do a lot more of the sort of building a network, like a compendium of memories, and working through them with your PTSD clients rather than just a lot of float backs.
Yeah. So focusing, so you don't have to do the float back. It'd be just like, okay, so this is the number one ticket item. Okay, so there's that. And then one thing you would want to do that with that sort of stuff as well is you get a nickname for that memory. Call it the car park memory rather than go into detail on this sort of stuff about what that memory was. You might be like, that's the car park memory. Okay, and then you can kind of start to not to avoid it, but so you have to kind of go into the.
But even that can be powerful initially, just to map them out in a verbal way, and then just touching them like that to say the car park memory, or can they tolerate even that, just selecting the memory for a second?
Car park, department store, then it's breakfast at grandma's house. These different memories, and you've got them based on themes. So I would probably look at theming them out and trying to get this.
Okay, I've got to ask you an EMDR question.
Yep.
One that came through. This actually my question.
Rob from
Rob from Sydney. You worked in the trial. You're in both arms of the trial. EMDR, clearly, it's an evidence-based treatment for trauma. It seems to be equivalent to imagery rescripting, based upon the recent RCT. I'm interested in what clients do you suspect might be a better fit for imagery rescripting versus EMDR?
Look, I mean, this is just my position, my thoughts on it. Is that EMDR is a bit more free associative. It's like, so you get the image and the beliefs and the cognitions and the words in your body, and you're doing the processing, and then okay, stop. What do you notice now? So it's a lot more. Therapist isn't involved. They don't know where the client's mind's going or emotions are going or their attention's going. So with clients that have got really severe trauma, where they don't have any models of kindness or compassion, this sort of stuff, they can go all sorts of different places and you don't know. So my gut feeling is that clients with sort of more very to have no decent attachment figures like that, so sometimes with clients you have one really horrible attachment figure and you got another one that's actually kind of meets some needs, so there's some sort of cancelling out of there's some corrective experience that breaks the rule. But if you have these clients with like complex trauma where it's like there's no models of decentness, you're going in, you're doing the work, you're keeping the client in the window of tolerance, you're providing the model, I would argue that might be more helpful. And I think that's the way that the research might sort of head, maybe kind of thing to look at. Yeah.
Makes sense. Okay, final question that I've got here. What tips do you have for early career therapists regarding becoming more confident in working with trauma? What would you say to your, 25-year-old self as you're getting into trauma work?
So I used to, I think this idea of like, I'm going to mess them up more is a problem, so there's difference between going in gung-ho and getting stuck in and not being cavalier, but there is also a problem where we have this idea that I'm going to mess someone up just because we're talking about it. So let's not talk about that. Let's talk about skills and this sort of stuff. So, there's some basic skills that we need to know about. And, as a therapist, we can avoid talking about these things and avoid dealing with it. But, I think a decent schema therapist would probably massively benefit from some knowledge around trauma and particularly imagery scripting, because it's a part of the treatment, so to get a bit better at that. This idea that, it's not about the content. So, worrying about, do I say this? Am I allowed to talk about this? It's not about the content, it's about the legacy that the person's got. It might be that the client has a really horrible memory, but really, you just have to think about what would a good person do? What would a good parent do about meeting need? So if your little child came to you and said, "Dad, this is happening to me," and you went, "Oh my God, look, we can't talk about it," then that wouldn't necessarily be useful for them. So
I think supervision's a big thing on this too.
supervision,
Right?
working out what the blocks are for yourself. Therapists, this sort of stuff can activate therapists' own schemas and stuff. So it's really, really helpful to get aware of that and know what that's about. As well, as things like the ACE study talks about, there's lots of us that have had traumatic events that have happened to us, and we're dealing with these sorts of traumatic events too. So, that could be hard for us to deal with, and we might really want to deal with that because it activates things in ourselves. So it's, looking at our own limitations and experiences, and so.
Nice one.
Game on. Okay, guys. Well, we'll close off now. Look, if you're interested in doing any of these training, we're often traveling around Australia doing workshops, but we've got a bit of more of an international audience now. I think there's quite a few people here, probably a third of people logged in or watching this overseas. But we've got a big kind of swag of goodies and training for people that want to learn more about schema therapy. We're going to be developing this. We've got 6 at the moment, but I reckon we might have 10 by the end of next year, maybe. And
so we've got courses on things from eating disorders, schema therapy, eating disorders, schema therapy online, integration of ACT and third wave therapies into building the healthy adult, more foundational courses in schema, right? So a sort of course 1, course 2, and as well as online intensives, for the purpose of accreditation.
Yeah. So we've got these 2 intensive courses that are coming up. And look, all our training really is about engaging. We personally, me and Rob, we're sick and tired of seeing training that is boring, uninspiring, and stuff that you just don't feel connected to. So hopefully, we might see you some point in time. But check out the website, Schema Therapy Training Online, and you can get some more information.
Awesome.
Excellent.
Thanks, Chris.
See you, Rob. See you guys.
Thanks, everyone. Thanks for coming. Hope to see you around. Bye.
Bye.